Yeah, very good afternoon. Hello.
Good afternoon, sir.
Yeah, very good afternoon. Am I audible, sir?
Okay, sir, audible.
Yeah. I, I seek permission from your side. Shall I start or anybody about to join? Or shall we wait for 5 minutes?
Kindly 5 minutes, please.
Yeah. Okay. The screen size is full now, sir? Already. I want a confirmation about screen size, sir. Is it full? Is it visible for all of you? Screen size? Anybody?
Sir, visible, but one uh, page show, sir.
Yeah. Palms Chiropractic College since 2003. This is the one page.
Uh,
Now page has been changed for you.
okay, visible, sir.
Yeah. Thank you. I am also visible now, my video.
Yes, sir.
Yeah. Okay. Thank you. Yeah, shall we start?
Okay, sir. Start.
Okay. In last class, we have discussed about Thomson basic protocol, where we have discussed about negative dairy field, cervical syndrome, and X dairy field, as well as double cervical syndrome. So moving forward, before that, I wanna revise the last class before going for the dairy field positive. So as all of you knows that in case of Thomson basic protocol, we are checking for the leg length. This leg length checking has been invented by Derifield. Later on, Clay Thompson has improvised the leg length as well as drop table technique. When it comes to negative Derifield, here we have got two positions for the patient. First of all, patient will be in prone lying position with the extended leg. In case of extended leg, we are looking for the leg length. Before looking for the leg length, we have to position the patient in such a way that patient must be in very much comfortable position. Then during leg length checking, we have to keep in mind that we have to follow protocols. Like in case of prone position, the therapist side will be towards the caudal side. Then we have to observe from the external occipital protuberance first, then midline, that is gluteal line, then mid of the knee. Always we have to see the dominant eye, see from the dominant eye. Now, in case of negative Derifield, in case of Thomson Derifield technique, always we do tell extended and flex leg, extended leg and flex leg. During extension, if legs are equal, we need to take the legs in flexion position, that is always about 90 degree or more than 90 degree. It should not be below the 90 degree. So in this, what exactly will happen during extended position in negative dairy field, during extended position, the legs will be long. In case of flexion, the leg's limb length will become short, shorter than the other leg. Then it means that dairy field negative, it indicates dairy field negative test. In case of positive, it will be more than the other comparative leg. So in case of dairy field negative, most probably two possibilities are there. One possibility is cervical syndrome. If you don't find cervical syndrome, there is a possibility of the change in the sacrum. Change in the sacrum. Because in case of negative dairy field, we are not at all looking for the ileum. Obviously, in case of sacrum, there is a position that is called as anterior inferior sacrum, that is AI sacrum. AI sacrum, in case of AI sacrum, you will find always AS ilium, anterior superior ilium. But here we should not go for the correction of the AS ilium. We have to go for the correction of the AI sacrum. So, if you find negative dairy field, always we have to check for the cervical syndrome first. Cervical syndrome first. Then, if you don't find anything in cervical syndrome, you can go for the sacral sacral checking. Sorry, sacral checking. Then, if you don't find anything in cervical syndrome, or if there won't be anything in negative dairy field, one more thing you have to see for the X dairy field. What exactly is X dairy field? This is negative dairy field, then positive dairy field. Then we have to check for the cervical syndrome. Cervical, in case of cervical syndrome, always major subluxation will be of C2 always. If you find the subluxation in the C2, you have to correct the subluxation. If there is no C2 subluxation, you have to look for the other rotation in the other vertebrae. Here, usually what exactly will happen during the extended leg, patient need to rotate the head one side. In during the rotation of the leg one side, the legs will become equal. If it is equal, that means that it is a cervical syndrome. Let me revise one more time. Negative dairy field, leg short in extension, stays short in flexion. Rotation of patient head has no effect on leg length. In case of positive, leg will be short in extension. It will get equal or more than the other leg in flexion in case of positive dairy field. In case of cervical syndrome, leg will be short in extension. During the rotation of to the either side, it will become equal. If on rotation to the right side, if leg will become equal, you have to find the nodule to the opposite side always. If on rotation to the right side, you have to find nodule to the left side. If there is a left side nodule, it means that right side cervical syndrome. If there is no nodule, but still it will become equal leg in case of extension, maybe the possibility of the atlas subluxation, possibility of the atlas subluxation. Now, in case of X dairy field, legs appear level in extension. Upon flexion, one leg will shorter. Then ask the patient to keep the legs in flexor position with shorter leg. Then ask the patient to rotate the leg to the one side. During rotation, if legs will become equal, it means that there is a possibility of the cervical syndrome. If leg length doesn't change, again you have to look for the negative dairy field, that is AI sacrum. When coming to the bilateral cervical syndrome, in case of bilateral cervical syndrome, during extended leg, legs will be always equal. During this during extension also leg will be equal. If you go for flexion, legs will remain again equal. In this scenario, what you have to do at the in the extended knee position, ask the patient to rotate the neck to the one side. If at all right side rotation, right limb becomes short, there is a possibility of the bilateral cervical syndrome. Either it will be short to the right as well as to the left. But keep one thing in mind that during right rotation, if right leg becomes short, and during left rotation, if left leg becomes short, it means that patient has got bilateral occipital syndrome. Always cervical syndrome is nothing but bilateral occipital syndrome. Maybe there is a possibility of the anterior superior occiput, AS occiput. If there is a posteriority in the occiput, then scenario will change. Like on rotation to the right side, left limb will become short. On rotation to the left side, right limb will become short. This is about bilateral cervical syndrome. Now, we are familiar with negative dairy field, positive dairy field. In case of negative, extended short, while flexion, again it remains short. In case of positive, extended short. In case of flexion, it will become long. During the flexion, there will be a feeling of There will be ratchety film because of the rectus femoris muscle. Then, in case of cervical syndrome, rotation to the one side of the neck will lead to the lengthening of the same shortened leg in case of cervical syndrome. If you don't find anything in cervical syndrome, you have to check for the sacral dysfunction. One more thing is that is external field. In case of external field, during extension, both legs will be equal. During flexion, it will be again equal. During the flexion, you have to ask the patient to rotate the head to the right or left. During rotation, if it becomes short, again you have to look for the cervical. If length doesn't change, you have to look for the again sacral dysfunction. And one more thing, bilateral cervical syndrome is always a occipital problem. Most probably anterior superior occiput in 80% of cases. Posteriority is very low. During bilateral cervical syndrome, rotation to the one side, same side will be short in case of AS, opposite side will be short in case of PI. This is all about negative, positive, cervical syndrome, external field, and bilateral cervical syndrome. In last class, we have discussed about key abbreviations like these all are the key abbreviations: negative dairy field, positive dairy field, CS is cervical syndrome, ADJ stands for adjustment. SAC is sacrum. Bilateral cervical syndrome BCS. Here we have to see for external field. LOC and LOD is very important for all of you. LOC is nothing but line of correction, whereas LOD stands for the line of drive. PP is patient position, DS is doctor stance, CH is contact hand, numbers will be there for contact hand. Then CP is contact points, and SCP segmental contact points, LOC line of correction, TP is the turk, LOD is the line of drive. Then, sorry, see, in case of if you don't find bilateral cervical syndrome, one more thing in case of cervical syndrome, there is one more thing that is known as overcompensatory cervical syndrome that has got link with the T1. Wherever there is a rotation of the C2, always T1 rotation will be always opposite side. If C2E has got rotation towards the left side, T1 will be always right side, where you will find the trigger to the opposite trapezius in the dorsal area. Then if you don't find cervical syndrome positive, you have to check for the trigger points. Trigger points will be like medial to the knee. What happened? Screen sharing. Are you observing screen sharing? Yeah, cup. No, one minute. Yeah, correct. It is coming like this. So trigger points, it is not visible. Let me tell. Medial of the knee will be one trigger point. Then you can have the trigger point on the PSIS. Then pubic tubercle, one can have trigger point. Then one more thing is the posterior ischium. If you find any two trigger points, it means that there is a problem with the sacrum. Then directly we can come for the 5 point drill for the adjustment. In 5 point drill, to make the constant arch, what we have to do is, first of all, we have to make your hands like this. This is the arch. Then join finger to finger. Then total pesiform area. Then thumbs. This is first count. This is first count. During second count, what we have to do is we have to separate both the thumb. Both the thumb. Then during third, we have to separate this. Then fourth will be this one. Separate both the hands. One is the adjusting hand, one is the anchoring hand. During toggle recoil technique, we are using always pisiform as a nail. Pisiform as a nail and this upper pisiform as a hammer. This will be nail, this will be hammer. Actually, in case of palmar corrections and adjustment till L2, L3, we are using always caudal hand. If it is the caudal hand, always right side caudal hand will be nail and cephalite hand will be always hammer. This is nail, this is the gauntlet arch. We have to practice this. Indeed, I am not doing well. We have to practice maximum to get this gauntlet arch. And one more thing, during the palmar adjustment, we have to keep always low arch. During the toggle recoil, we have to keep high arch, low arch and high arch. This is the five point drill for the to make the gauntlet arch. 1, 2, 3, 4, 5. Then next, this is the palmar style palpation. Always we have to palpate in sitting position during the palmar time palpation. Why? Because in case of prone lying position, there is a pressure from the abdomen side which may give wrong information about the spinous process of the vertebra. That is why it is always better to go for the palmar style examination in sitting position. First, you are looking at cervical palpation, then this is thoracic palpation. This is this middle finger. We have to palpate the spinous process always, like this middle finger. This is for spinous process. The palpation must be very gentle, isolating the parts. We have to go for the palpation. Always you have to have the feather touch. You should not torture to the human body. How much gently you are palpating to the body, that much of information you will gain. How you are going to hypothesize also matters a lot during the palpation. If you are very fair during the palpation, it means that you have to go for the feather touch always. You should not torture the body. You have to go for the feather touch. Cervical palpation first, thoracic, then lumbar palpation, then sacral. This is for PI ileum, then iron and EX ileum. Then after palpation, you have to go for the correction depending upon the listing of the vertebral subluxation. This is for PI, posterior inferior, L4, L5, posterior inferior right. This is the gauntlet arch. Depending upon the area we have to go for the adjustment. This is for base P. Base P always. This is the base P and this is apex P. Apex, posteriority of the apex, posteriority of the base. This is for base P. Then this is for apex P. Okay. We can go for practical demonstration. Are you looking at the table now? Is it okay for all of you? Am I visible?
Yes, sir.
Yes. Okay. Raymond, you can do one thing. You can take laptop like this. Okay. So this is the Thomson table what we are using. So to
Hello,
position,
Hakeem.
we
Hakeem.
have to place the elbows. Yes.
You have to turn off the sharing.
Sir. Sir.
Turn off the screen. Yeah,
Okay. Okay. Sir.
it
Screen
won't be
share.
your report.
Sorry, sir.
Yeah, you have to turn it off. Screen share. Yeah, that's good. That's good. That's good.
Sir, is it okay, sir?
Good. Good. Now that's good.
Thank you, sir.
Yes, sir.
Sir, we have to position the patient in such a way that the elbows must be 90°, shoulder 90°, both the sides. If patient has got problem with his shoulder, let him take the position like he wants. Then to relax the position, we can do supination of the hand to relax the patient. So the therapist stance will be towards the leg side. Always there is a difference between AMCT activator method chiropractic technique and Thompson. Now we are dealing with the Thompson. That is why during this we should not go for the load bearing position. Here what we have to do is we have to take these grabs. This is for to hold the shoes, this one, and the patient's feet must be in plantigrade position. This is everted foot. Now I have taken it to the normal and I am looking from my dominant eye. Wherever my dominant eye is left eye, that is why I am taking left eye toward this. This is EOP, external occipital protuberance, gluteal lines, then knees. Then before that, you have to ask the patient to squeeze the fish. Squeeze it, squeeze, relax, relax. This is the stance. If you don't have chair, you can stand like this. Then, now I am checking for the limb length. Now what I am finding is right is short. During extended position, right is short. Now I am taking leg to the flexion above 90° or up to the 90°. Again, short is remaining short. Short is remaining short. It means that patient has got negative dairy field. In this scenario, what we have to do? We have to check for the cervical syndrome. Can you please turn your head towards right side? Right side. Keep it. it is same. Then right side, left side. Now the limb length has increased. Now what I have to do is I have to check for the cervical syndrome. Taking it in neutral position, I have to check nodule. The patient has got left cervical syndrome. I have to check nodule to the right side. Yeah, here I am finding mass at C2. At C2. After finding the mass, and we have to reconfirm this. So I have to go for the pressure test first. This is the pressure test. Within 3 seconds, I have to go and recheck it. Yeah, it has become too long. Then I have to reset it, but taking the limb to the 60 position, 60 degree of knee flexion. Then again to reconfirm, I must go for the stress test. This is stress test. Now it is short. Here I have to go for the adjustment of the C2. Adjustment of C2. During adjustment of the C2, the position will be towards the affected side. Patient has got left cervical syndrome. Now what I have to do is, in case of left cervical syndrome, posteriority is towards the left side. Now what I have to do is, I have to take patient head towards my side, little bit rotation. Then this is the knife edge what I am using for the corrective hand. This one. Then opposite hand will be catching hold of zygoma, that is zygomatic. Then I'll give little bit traction towards the zygoma. Then I'll go for adjustment. Let me raise it. Sorry. It must be very gentle. Towards my side. Then I am catching hold of zygoma. Then this is my stance. Go for, sorry. T2. Go for third. Then I'll come back slowly. In case of cervical region, one is enough. Apart from that, you have to go for 3 times of adjustment. Then I look for the leg length. Now this is long. Then after I have to again recheck by taking it to 60 degree. Still it is short. It means that after correction of the C2 also, the problem is still existing. So for this, what I have to do, I have to look for again C1 correction. Then I have to see for other things like overcompensatory cervical syndrome also. If it is C1, I can utilize toggle recoil for C1 correction. I shown you in last class. As well, I can use the activator method also. AMCT is only one. So if patient has got, this is about negative cervical syndrome. If he doesn't have cervical syndrome, again I have to go and check for the triggers. That is medial knee, posterior to the ischium, then pubic symphysis, then PSIS. We have to find minimum 2 trigger points if there is no cervical syndrome for this. If at all patient has got X dairy field, in case of X dairy field, what exactly will happen? During extended legs, equality is there. If I go for flexion, still legs will be equal. Then ask the patient to rotate the neck to the one side. During rotation, it will be short. If it doesn't become short, it means that again patient might not be having cervical syndrome, he might be having sacral dysfunction. Again, we have to go for to look for the other triggers, what I have told you earlier. This is about X dairy field. Then after X dairy field, we can go for the bilateral cervical syndrome. In case of bilateral cervical syndrome, during extension, the legs will be always equal. Then ask the patient to rotate the neck to the one side. Can you rotate neck to right side, please? Keep it, okay. Then come to the neutral position, stay for 3 seconds, then left side. Yeah. If at all, during right rotation as well as left rotation, if legs are short, I mean during right rotation, right will be short, during left rotation, left will be short. It means that the patient is having bilateral cervical syndrome, which is most probably the involvement of the occiput. That too, anterior superior occiput. He is turning to the right, right will be short. He is turning to the left, left will be short. We have to go and adjust the occiput, that is AS occiput. In case of P, posterior superior occiput, if patient is turning head to the right side, left limb will become sharp. During left rotation, right limb will become sharp in case of posterior occiput. In case of anterior superior occiput, the Thomson drop table will be the better option for all of us, all of you. In case of posteriority, better to go for the constant adjustment in sitting position. Now, let me show you the adjustment of the anterior superior occiput. In case of anterior superior occiput, assume that this is atlas C1, this is occiput. This will come in proximity. This will be close. Now, what here we have to do is, this is external occipital protuberance. Just side to the external occipital protuberance, we have to keep our two thinars. Way. Then always the position of AS will be like this. What we have to do, we have to catch hold of side of the external occipital protuberance. Then we can go for thrust. That is most probably recoil will be good option. This is the position you have to hold. Then during recoiling, your line of direction or line of correction must be towards the superior side, and you have to do this way. This way. This is the occiput, position of the occiput. You have to go for the line of direction this way. This. I don't want to disturb him. I'm showing you. Okay. Superior, then rotate towards head side this way. This is the line of correction for the bilateral cervical syndrome. If it is anterior superior occiput. If it is posterior, better to go for the gauntlet type of adjustment. That will be better. This is all about negative derivative. If you find positive derivative, in case of positive derivative, always extended leg will be short. During the flexion, it will become equal or more than the opposite leg. This is positive derivative. My reference limb is right leg. This is the extended position. I will go all the way to the flexion. During the flexion, I may feel rigidity experience from the quadriceps muscle, that is rectus femoris, like this. If I am feeling rigidity feeling, it will become long. Now, what I am finding, this is the scenario where you are getting extended short. During flexion, it is becoming long. It means that the Derifield test will remain positive. If it remains positive also, according to new practice, again we have to go and check for the cervical syndrome. Check for cervical syndrome, then go for the, maybe there is a masking from the cervical area. That is why it's better to go for cervical syndrome first, then go for the positive derivative. In case of positive derivative, always there will be a involvement of the ilium, that is posterior and inferior. Posterior and inferior. See, in case of posterior inferior dysfunction of the ilium, again we have two kinds of dysfunctions. There may be upper boot subluxation or lower boot subluxation. That we have to check regarding what is the problem with the ilium. Is it upper boot or is it lower boot? For that, we have to make the patient in supine position. Come in supine position. As all of you know that right side is the reference side, reference limb. So ask the patient to flex the arm with straight elbow. Here my reference point is anterior deltoid muscle and this is inguinal ligament from ASIS to the pubic symphysis. For example, ask the patient to take hand back side and you have to register it. Take it back. Now I am feeling much power. Now, in case of ilioinguinal ligament, I am coming from down and I am going medially, medial, then take it back. Now I am feeling much resistance, no problem with this. If there is a problem with ilioinguinal ligament toward the pubic tubercle, it means that there is a involvement of the PI ilium, that is upper boot. If it is a problem of the lower boot, ligament, ilioinguinal ligament will be, there will be weak hand in the, if I go for the medial position to the ilioinguinal ligament from the ASIS. I am taking it from ASIS to medial. Then, yeah, if it is weak, there may be a chances of lower boot involvement. If at all, if there is a involvement of the upper boot, we can adjust the PI ilium in supine position itself. But for that, what you have to do is, you have to take a lumbar piece as well as pelvic pieces. Both the pieces you have to take up. Now there is a problem with my table for pelvic piece. I can go for lumbar piece. This is for PI ilium upper boot. This is the stance. Stance. And it must be very, very gentle since we are dealing with the ilioinguinal ligament. Yeah, now it's okay. I am adjusting for the upper boot, that is pubic tubercle, and this is my Gonstead arch. This one, my line of correction must be towards the ankle of the opposite limb. Repeat it 3 times. This is about upper boot. If it is lower boot, we have to take the patient position in prone position. Coming prone position. Now reference leg is it is left side. During this, we have to stand towards the side of correction, or you can stand opposite also. I am standing towards the side of correction. This is the pisiform what I am using this way. And one more hand, during the practice of the Derifield, he was about to catch whole of the opposite ilium, but Clay Thompson, he has changed that and he was catching to the posterior ischium of the opposite side. Come down a little bit. Yeah. Clay Thompson, Derifield was catching like this. Clay Thompson, opposite of the ischium, opposite ischium. Why? Because in case of PI ilium of left side, there will be anteriority of the ilium of the opposite side. If it is anterior superior ilium, the ischiatic tuberosity will come posterior. That is why it is better to catch hold of and stabilize the ischiatic tuberosity. Then PSIS just beside the PSIS one hand with Gonstead arch. Again, here also you have to take up both lumbar and pelvic pieces. Sorry, I have problem with my table. I am utilizing only lumbar piece. This is the grasp. This is ischiatic tuberosity. All the way, I'll go for 1, 2, 3. This is for posterior inferior ilium for Derifield positive. If you have corrected everything, trigger points are not there, still problem persists, we have to look for the L5. We have to look for the L5. So to look for the L5 again, we have to go for the palpatory technique. Then after making the proper listing, we can go for the adjustment for the lumbar area. During adjustment of the lumbar area, we have double thumb, one, then crossover, then single hand. 3 techniques are there. One is single hand, number 2 is double thumb, number 3 is crossover. Let me show all 3 techniques for all of you. Now, let us assume that there is a problem with L5, that is left side. Now, if I want to correct this, if I want to use single hand contact, I have to contact in this way, single hand. Because L5 means I have to use the caudal hand always, not cephaloid hand. Caudal hand, gauntlet arch, again pisiform this way, single hand contact. Then during this, I can hold the anchor the single hand with this hand like this to the thumb. Then go for press 1, 2, 3. This is single hand. If it is double thumb, this is the technique double thumb. Always during the adjustment, during double thumb technique, wherever there is a posteriority or there is a problem, there you have to put effort, much effort. Double. Then this is for crossover, this technique. Again, pisiform for the caudal hand, cephaloid hand will be crossing the opposite area. This is cephaloid. If you are using the Thomson drop table, you have got very easy and very effective techniques in Thomson drop table. This is the way we have to adjust the different segments of the lumbar spine. You can use till L1, L1 to L5, same thing. Depending upon the superiority, depending upon the inferiority, depending upon the listings, you have to go for the adjustment. It may be PRS, PRI, PLS, PLI. Depending upon that, we can have the different stance. That Jay sir will tell each and every position. Okay. So, any doubt till here, sir? Unmute everybody. Unmute your mics. Any doubt? Do you want anything? तो अपन सहा बिधान चंद्रा आलमीन हुसैन. Am I audible?
हकीम भाई आवाज थोड़ा कम है.
हाँ, अभी आ रहा ना आवाज?
जी सर, thank you. I understand maximum technique of your. Thank you, sir, all of you and your good lecture. I enjoying of your today class.
Thank you so much, sir.
Thank you, sir.
ओमकार भाई,
बोलो.
Thank you,
any
sir.
doubt, sir?
हाँ,
No,
थैंक
sir.
यू. अभी लेक्चर अच्छा हुआ.
जी.
राकेश भाई से बात करनी है. हकीम भाई.
राकेश भाई है अंदर?
हाँ. बात करो.
राकेश भाई?
हाँ, वो बाद में कॉल करते हैं बोले.
ओके ठीक है
वो
ओके.
टॉयलेट जा रहे हैं.
अच्छा हाँ.
आ रहे हैं,
सर,
बात करते हैं. और आपका
लेक्चर बहुत
लेक्चर
अच्छा
कैसा
हुआ,
चल
सर.
रहा है? बढ़िया रहा. मैं सॉरी, मैं थोड़ा लेट ज्वाइन किया.
थैंक यू. थोड़ा आने में मुझे भी लेट हो गया, थोड़ा गड़बड़
नहीं,
थी.
कोई
अभी
नहीं,
आगे
कोई
बढ़ते
नहीं.
जाएंगे, अभी अच्छा होते जाएगा.
बढ़िया है.
जी.
चलो, बाय.
बाय ओके थैंक यू.
हाँ, bye.
Thank you, sir.
थैंक यू.
Thank you, sir.
Thank you.